I'm speaking with Michael Dinneen, M.D., Ph.D., and the Director of the Office of Strategy Management for the Military Health System, a position he assumed after retiring from the U.S. Navy in 2005. We're going to talk about a new kind of healthcare organization called an Accountable Care Organization, or ACO. An ACO is designed to provide a continuum of care to patients even as they move from one medical facility to another. A psychiatrist by training, Dr. Dinneen served as Director of Medical Services at the National Naval Medical Center in Bethesda, Maryland, and he also served as a special psychiatric consultant to the Secret Service and the State Department. He also has special expertise in military psychiatry and psychological trauma acquired during the Desert Shield and Desert Storm campaigns. Dr. Dinneen, welcome to the program.
Thank you.
What exactly is an accountable care organization? What's the purpose of that type of organization?
Well, the purpose of the organization is to be accountable for something. And in the military health system, we've said that we want to be accountable simultaneously to have people ready to face the challenges they may face in health, whether they be infections or accidents or those kinds of things. We want to be able to say that we're accountable for improving the health of a population that we serve. That's number two.
When you say accountable to whom?
It's a great question. In the military health system, we're accountable first to the Secretary of Defense, but really we're accountable to the American people. They're the ones that pay the bills. But more importantly, we're accountable to each and every patient to be sure that they feel like when they come for care that they'll get something that's of very high quality and that won't harm them. And that's the third component. Beyond readiness and population health, it's an experience of care. We're accountable to the patient to provide an experience of care that's safe and effective and efficient and that makes them feel like someone actually puts them at the center. And then finally, as Secretary Gates says, the cost of healthcare in this country is unsustainable. So we have to be accountable for being good stewards of the government's money or of the taxpayers' money.
Well, is there a problem with the way health care is delivered now? Usually an organization is designed to solve a problem. So what's wrong with the system now that it needs a new organization?
Well, there are basically two problems from our perspective. One problem is that we pay for the wrong things. Right now, in this country, we pay for volume. So we have a fee-for-service model. So the more that is done for a person, the more the providers or the doctors and the hospitals get paid. So that essentially provides a tremendous incentive to provide lots and lots of services, and that's one of the things and especially use lots and lots of technology, and that tends to drive costs up. The lower cost interventions like coordinating care, doing education, helping with nutrition, those aren't actually even paid for in the current system. So one of the problems that needs to be fixed is the lack of incentives for health. We now have incentives for sickness. And so that's one thing that has to be fixed.
Now you're largely talking about the military healthcare system.
Actually, we're immune from that. We don't have that problem. It's in the civilian healthcare system where those problems are because we're given a total amount of money to take care of all of our patients over a period of time.
Now don't the insurance companies always play a very big role in this? The hospital and doctors will recommend as many tests and as many treatments as the insurance company is willing to pay for.
The insurance companies, I don't think, are the villain that many people would say. The insurance companies are obliged to do what the doctors decide to do. And in addition, they don't have much control over saying, you should really change your practice pattern, nor should they, because they're not in a position to make a good judgment about that. What's really hurting this is the policy we've set over the years that says the United States government sets the fees basically through Medicare, and that we have this fee-for-service model, and that we will pay for a service whether it helped you get better or not. And so that to me is the essence of the problem. On the other side, on the healthcare delivery side, so we've got this problem with what we reimburse for. On the delivery side, it's like a cottage industry, with each doctor by themselves doing the best they can, but there's very little connection between what one doctor does and what a specialist does and what a hospital does. The accountable care organization tries to tie together the doctor with the specialist with the hospital and make them together accountable for the outcomes for a patient over time.
So what would this type of organization look like? Who would its members be? Right. Would it be a hierarchical organization where somebody in the organization decides what treatment you're allowed to get or what tests you're allowed to get?
Well, actually, what it would be best based on is the best evidence that's out there, and this is where we really want to leverage technology so that doctors at the time that they're seeing a patient will actually have access to decision support so that they can say for a diabetic, gee, you haven't had your blood pressure in control, or you need to have better control of your cholesterol, or we need to be taking care of your kidney. And that would be supplied by a very powerful electronic health record. The other thing that technology would help us with is connecting the dots between what just happened at a hospital and then what's happening back when the person comes back to their primary care doctor. And that's not happening frequently now.
So you're talking like something like a national healthcare database where your entire medical records are all stored in cyberspace and any doctor who treats you has instant access?
That would be the long-term vision. That's done and in a very safe way, so it doesn't lead to problems with privacy, invasions of privacy and such. Probably the best example of electronic health records that are working now are in our system, in the military health system, the Department of Veterans Affairs, and Kaiser Permanente. But Kaiser Permanente has done particularly well in that what they have is a single electronic health record where not only do the doctors have access to all the information, but the patients themselves do. And the patients now are able to see what's gone on every time they've touched the Kaiser system so that they can take personal charge of their own health. And I think that's where the real advantage is a truly accountable care organization will be accountable in real time to the patient, so that they get their lab results right back. They know how well their system is doing in treating the illness that they have.
Are there any ACOs already existing? Has this concept been tried out?
That's the interesting thing, that once you give something a name, you think it's fully defined, but it's really not. So it's really a concept that's evolving over time. We would like to think that we are already an accountable care organization because we have a system of say, we have nearly 30,000 doctors that work with a staff.
You're talking about the military
health
system now?
Right? And we own our own hospitals, and we have an electronic health record that ties it together. So we are already functioning as an accountable care system. There are also a lot of pilots going on now with relationships between, in the civilian community, groups and hospitals to do that kind of an accountable care organization. And then there are the hospital organizations, systems that you might have heard of, like Kaiser Permanente and Cleveland Clinic and Geisinger and Intermountain Health, that are already functioning as accountable care organizations.
Now, I'm a little bit confused about the name accountable care, because aren't doctors and hospitals already supposed to be accountable?
Yes, it's a wonderful question, because right now doctors tend to be accountable for the care they provide at that moment. So they're accountable for the quality of the visit, but they're not accountable for the care over time and space. And what this does is it says we need someone who's accountable, if you're a diabetic, not just for how well that office visit went or how well it went when you went in to see your nephrologist about your kidney problem, but how well did we do with you to manage your diabetes over time so that you can avoid things like renal failure or going to the hospital lots of times or getting in trouble with diabetic ketoacidosis.
So does that mean that there would be, say, one person who is ultimately responsible for coordinating your health care, no matter how many different doctors you went to see?
That is the goal. That is what's missing in healthcare in the United States right now. There is no one who is responsible for all the aspects of an episode of care, from the time someone says there's something wrong to the time that you're all better and back to your fully functional state. And if we could, if that could be where the country goes, that says there's like, one person calls it an offensive coordinator, so that all the players on the team that takes care of you, somebody's making sure they're all doing their part and they're all working together to work like accomplishing a play in football.
Now, how would this work from the standpoint of the patient? Would this person who is ultimately responsible for you have a personal relationship with you or know you, or?
Right. In some cases, we think that the centerpiece of the accountable care organization is something called the patient-centered medical home. And there you would have a personal physician who would be the architect of all of your care. But for people with more complex illness like cancer or multiple chronic diseases, you might need what's called a case manager or care manager that would have that relationship to you and could in a more intensive way reach out to all the people that are involved in your care.
Now, the fact that you create an organization and you give somebody this title of being in charge of your health care, does that in itself make it happen? Because to manage a large caseload, for example, it's hard to see how you could spend a lot of time on any one individual.
Right. One of the things that we're that is a learning in trying to go this way is that we've been underspending in this country in primary care. And so we've forced primary care doctors to have very large panels of patients and insufficient time to really do what's necessary to help them chart their course for health. And so some places, there's a group in Atlantic City right now that have actually doubled the amount that they're spending on primary care. And by doing that, what they've managed to do is reduce the amount of inpatient admissions. So the total cost of care for the patients has been reduced, while the amount that's been spent on primary care has actually been doubled. Because what we think now is that if we got much better primary care, we'd essentially be emptying out hospitals in this country, because a lot of the hospital admissions are due to lack of coordination and lack of good management of outpatient illness.
What do you think is the most wasteful part of the healthcare system? There are often proposed cuts here and there on little things, but what kind of area do you think would be best to cut where we could achieve the most savings without compromising care for individuals?
That's really risky. So most people that have studied healthcare costs in this country would say that approximately 1/3 or more of all healthcare delivered in this country is waste. The problem is identifying which that 1/3 is, because the other 2/3 are very valuable things that we're doing to help people get better once they've gotten sick. And I think that many of the efforts to cut out waste have been like taking a sledgehammer to something where we really need a scalpel. And what we're hoping to do is to attack this in a very thoughtful way. So the president this year, President Obama, has actually just yesterday announced a new program where the effort is going to be primarily on eliminating unnecessary readmissions to the hospital. So about 25% of people in the Medicare age, if they've been admitted for congestive heart failure, they'll be readmitted within 30 days. We know that's unnecessary in many cases. So we're going to focus in on those people where there's both suffering and costs that can be avoided. Because almost everybody would agree, if we can do better outpatient care after people leave the hospital and avoid a readmission, that's both improved quality and reduced cost.
By outpatient care, you mean like sending a nurse to their house to watch over them, which would be cheaper than if they were in the hospital?
It's easier than that. We found that if people get a phone call within 5 days of leaving the hospital that just reinforces what they were asked to do when they were in their discharge instructions, that's a huge thing to reduce the readmissions.
So is the ACO largely an administrative type of organization, or is it involved in actually providing the care itself?
Some of us who just were on a panel talking about accountable care organization wonder if that term really ought to be used. Maybe we should just say accountable care. That really it's about moving from where no one's really accountable for the care of a person over time to identifying that person who feels accountable and then collaborating with others to get the best outcomes at the lowest cost.
Now, has anybody raised any objections to ACOs? Are there any possible downside?
Absolutely. I think, and that's in the realm that I'm not as fluent in, or I certainly don't have the expertise, and that's the fear that if doctors get in legal relationships with hospitals, that you could actually drive up costs, because those collaborations could lead to them being able to demand higher costs. So that's the fear, and because what we really want is we want lower costs, better quality outcomes. We in the military say is quality first, cost will follow. So if you focus on doing it right the first time, avoid those readmissions, don't expose patients to danger so they get infected while they're in the hospital, those are the things that will eliminate that waste you're talking about. By doing quality first, cost will come second.